What's the term atelectasis? So atelectasis occurs because a section of the lung, the alveoli collapse in a section of the lung. So what makes them collapse? Well, if you have a blockage in a bronchial tube by, say, a mucus plug in, say, COPD, or a lung tumor that's blocking some bronchial tubes, there's no oxygen getting to the alveoli. The oxygen that's left gets diffused into the capillaries, and there's no more ventilation to that area. So it basically collapses. All the alveoli just collapse, and we can see that on chest x-ray as a portion of the lung that's basically just had collapse on itself, and all the alveoli are now not being ventilated at all with air. Okay, so this can happen after surgery. So after surgery, patients are lying down, they're not getting up very much for the first day or two, say they're older, and they're not taking big breaths, so they're not ventilating parts of their lungs very well, and they develop atelectasis. Okay, when you develop atelectasis, and because there's no ventilation to that area, that's a perfect place for pneumonia to set in. So that's why we typically get post-operative patients to use an incentive spirometer, which forces them to take big breaths in and then to breathe out, and then big breaths in and then breathe out. So say, for example, someone's had heart surgery and it's really painful for them to take big breaths. Well, we know it's important for them to take big breaths, otherwise they're going to develop atelectasis. So we control their pain with opioids, so they're able to take big breaths, and then we give them an incentive spirometer at the bedside to take those big breaths that prevent atelectasis. Okay? Another example, someone who's in an accident falls off a roof and breaks 4 ribs on the right side of their chest. Well, they don't want to take big breaths anymore. It hurts too much. So what can we do for them to prevent atelectasis, which is collapse of a section of the lung and no ventilation to it, is controlling their pain again and providing them with incentive spirometry that they can do every hour to make sure that they're keeping those alveoli open and preventing a pneumonia from developing. So often we'll send patients for pulmonary function tests, and they're a test where we get a patient to breathe into a machine and we test their lung volumes. For example, how much air can they bring into their lungs? How much air can they force out of their lungs within, say, 1 second? Or how much air can they force out of their lungs in total, given as much time as possible? And that gives us a lot of information about lung function, right? How much can they inspire during an inhalation? How much can they exhale? And it gives us all kinds of different lung volumes. And that's important when we're trying to find out how severe is someone's asthma, how severe is somebody's COPD. Okay, so that's pulmonary function test, and we'll come back to that. A spirometer is basically a very simple little device that a patient can hold by themselves, and they breathe as fast as they can into the spirometer, and it tells us how fast they're able to get air out of their lungs. So that's really important in conditions such as COPD and asthma, where the main problem is that there's a lot of wheezing and a lot of mucus in the bronchial tubes, and they can't get the air out very easily. They can get the air in, but they can't get the air out, because when you exhale, the bronchial tubes get more narrow, and there's mucus in them in these conditions, and they have difficulty exhaling all of their air. So a spirometer test is a very simple test to do that can be done in a clinic or an emergency room to test someone's what's called peak flow, the amount of air they can get out as fast as possible. Okay, so either one of those can be used to diagnose respiratory conditions and the severity of them. On the right here, you see someone having a pulmonary function test. Okay, and the machine will read out all of the different calculations of the lung volumes, that is. Okay, so let's talk about pulmonary function tests. So these are usually done at a respiratory clinic or by a respiratory therapist, and it's really similar to the machine you saw in the above slide, right? So you have a patient that has maybe shortness of breath, and we're going to do pulmonary function tests on them to see their lung volumes and how much air they can get out of their lungs in timed intervals, say 1 second. So let's just talk about some volumes. So the first one is tidal volume, and that's just the amount you breathe in or out while you're just resting. So you'll see on this chart, it's showing you about 500 milliliters. What's vital capacity? Well, the respiratory therapist will ask the patient to take a huge breath, their maximum breath, and breathe out everything they have. And that tells us the vital capacity. How much can they breathe out in terms of maximum volume? Okay. What's forced expiratory volume in 1 second? That's the amount that someone can breathe out after they've taken, again, a huge breath, a maximum breath. How much of that can they get out in the first second? Because most of us can get the majority of our vital capacity out in 1 second. Patients with blocked bronchial tubes, such as in COPD or asthma, they have a really hard time getting their air out quickly, right? Those are conditions where you have wheezing with exhalation. Okay, so they usually have an easy time getting air in. The difficulty is getting the air out of the lungs. So that's a very good test to tell us how much can they get out in 1 second. Residual volume. Well, that's the amount of volume left in your lungs once you've completely forced out a vital capacity breath. Okay. What's total lung capacity? Well, that's just adding up all the lung volumes. So it's going to add up your inspiratory reserve, which is how much can you take after you're just breathing normally. That's your inspiratory reserve. How much can you exhale while you're just breathing normally, and suddenly someone just tells you to breathe out completely? That's your expiratory reserve. Okay. So the total lung capacity is just the addition of all the lung volumes, and this gives us a lot of information on lung function in a patient that has diseases such as asthma or COPD. Okay, so this next slide is just showing you some chest x-ray safety precautions and in terms of radiation exposure. So, and x-ray technicians will definitely know all about this, right? So how do you minimize radiation exposure, whether it's in a CT CAT scan suite or in radiology? Well, it's the distance away from where the x-ray is being taken it's what's being placed between you and the X-ray, for example, or any radiation, and it's the amount of time that you're in the area where there's radiation. Okay, so it's distance, what's being used to block, and the amount of time that you're being exposed. Okay, so what are some common symptoms and signs of impaired ventilation or impaired oxygenation? Well, dyspnea is just the subjective feeling of being short of breath. So somebody says, I feel short of breath, that's dyspnea. Okay? Just the sensation of feeling short of breath. Doesn't tell us what the cause is yet. They're just telling us that they feel short of breath. Coughing is a very common symptom, a respiratory symptom, right? It can be a protective reflex. It helps with clearing of mucus in the lungs or irritants in the lungs. It can be a symptom of asthma because asthmatics often cough because of all the mucus they have in their airways. And cough can also be a symptom of an infection, right? It can be a symptom of pneumonia or of bronchitis. Excessive mucus production, very common in pneumonia or in bronchitis. Remember, pneumonia is treated with antibiotics. Bronchitis in a healthy person is usually a viral bronchitis. In someone with COPD, chronic obstructive pulmonary disease, when they have a flare-up of COPD, which includes bronchitis, we treat COPDers with antibiotics when they have a flare-up. Hemoptysis is coughing up blood, and that can be an indication of a pneumonia, that could be an indication of a cancer, or a pulmonary embolus. Accessory muscle use is when you see someone, when you objectively watch them, you can see that they're working hard to breathe. The neck muscles are being used to force the chest to expand. So accessory muscle use means the patient is typically in some respiratory distress, okay? So a patient that comes in and they have COPD and they're hanging on to the table in front of them, and they have, you can see every time they take a breath, their neck muscles are being used to help take the breath. That's usually someone in respiratory distress. They're in a bit of trouble, okay? Chest pain is a symptom, potentially, of something to do with the lungs. So congestive heart failure can also present with chest pain, right? Because they may be having a heart attack or angina, and now on top of that, they're backing up fluid into their lungs. Chest pain can be a symptom of pneumonia, because when you have a pneumonia, the infection touches the lining of the outer lung called the pleura, and when you take a deep breath, it stretches the pleura and it can cause pain there. Okay, so chest pain is not uncommon with pneumonia. Now, you usually have other symptoms with pneumonia, such as fever, shortness of breath, phlegm. So it's not typically just chest pain. A pneumothorax is a collapsed lung. Okay, that's different than atelectasis. A pneumothorax means the entire lung has either partially or fully collapsed. And that's typically painful because in order for the lung to collapse, it's torn away from the chest wall, right? And the pleura, which attaches the lung to the chest wall, has a lot of nerve endings. So they typically have a lot of chest pain. Okay, so here's an example of accessory muscle use, right? So when this person inhales, they're using their sternocleidomastoid muscles in their neck to help move the chest wall. because they're having such difficulty getting air into their lungs. Okay, so let's continue on with some other signs and symptoms of impaired ventilation or impaired oxygenation. So a barrel chest is typically in someone with COPD or emphysema, where their lungs don't recoil well anymore. They're hyperinflated all the time. So they're always breathing at high lung volumes, because even when they inspire air and then they relax their diaphragm and their intercostal muscles, the lung is so damaged it doesn't want to recoil, so it just stays enlarged. So these patients we call having a barrel chest, because they're always breathing at high lung volumes. The lung is never recoiling back to normal anymore, because it's lost its ability to recoil from all the damage from emphysema. Okay? Adventitious breath sounds. So these are heard with a stethoscope, and they're just sounds in the lungs that can indicate fluid in the lungs from pulmonary edema or a pneumonia, if it's just heard typically on one side. If you have bilateral pneumonia, you would hear these sounds on both sides. Okay? And they can be crackles or crepitations in the case of pneumonia or pulmonary edema. You can hear wheezes from bronchoconstriction and mucus in the airways, which is very musical sometimes, right? Just the wheezing of the air going through these blocked airways. Stridor comes from an upper airway obstruction, typically in the trachea. So a child with croup can have stridor. And when they take a breath in, you can hear the air flowing because the trachea is narrow. The air is making a sound as it goes into the lungs. Or if someone, say a child, inhales a small toy by accident. They have it in their mouth, it goes into their lung, and suddenly they have stridor. That's an upper airway problem. Okay? It usually indicates some kind of blockage in the upper airway. Absent breath sounds. So when you listen to the lungs with your stethoscope, if there's fluid that's filling one side of the chest cavity, that's called a pleural effusion, it'll be silent. There's no lung there anymore. It's been pushed out of the way by the fluid. A pneumothorax, where the lung has completely collapsed, you won't hear any air, any breath sounds on that side, because the lung isn't inflating with inspiration. Wheezing, so typically expiratory wheezes in asthma or COPD. And that's just the whistling of the air through the constricted bronchial tubes. Okay? Inspiratory wheezing means that the asthma or COPD is even worse. If we hear inspiratory wheezing, it means that the patient is typically in big trouble, because the airways are so narrow that even when they take a breath in, the air is wheezing and whistling through the bronchial tubes, and typically it's only with expiration. Abnormal vital signs, so tachypnea, so rapid breathing in the setting of a pneumonia or in the setting of asthma, because they're just not getting their air out very well. So they're breathing really fast. Okay? Tachycardia, because the person's working so hard to breathe, say in an asthma flare-up or emphysema flare-up, they're tachycardic. And low oxygen saturations are an indication, of course, of a pulmonary condition, often because there's inability of the oxygen to diffuse into the capillaries. Someone who's sitting there using very short sentences, and that's all they can do. They can say 1 or 2 words at a time because they're so short of breath, can occur in really severe asthma or really severe COPD. Okay? typically, we will bring these patients right back. If they can only say 1 or 2 words and then have to stop and take a breath, then typically they're in respiratory distress. Okay, so what are some systemic manifestations of lung issues or lung disease? Well, cyanosis. So it's the bluish purple color of the skin or your mucous membrane, such as your lips, from hypoxemia, from low oxygen levels in the blood. Okay, so and there's an image of cyanosis on this patient's digits. What does an arterial blood gas value tell you? So we're going to go more into blood gases, but an arterial blood gas is really a calculation. So we take a needle, we usually puncture the artery at the wrist with the needle, and we take an arterial sample and process it for the following values: pH, PaCO2, PaO2, and oxygen saturation. Now, an oxygen saturation we can just get with a monitor, right? An O2 sat monitor. But an arterial blood gas is telling us how much trouble is this person in? Are they becoming acidotic? Is their CO2 very elevated in their lung, in their blood, meaning their lung is unable to clear the CO2, and they're getting into more and more trouble as the CO2 climbs, and it's an indication that their lungs are failing, right? Because they're not able to clear the CO2. Their PaO2 is also telling us how much oxygen are they able to get into their bloodstream. Is the pneumonia so bad that they can't get oxygen into their bloodstream? So these give us a lot of information. Mental status. If someone has a respiratory condition such as a pneumonia and they're restless, irritable, it usually means that their oxygen is low, right? The brain is sensing this low oxygen and getting restless. If they're lethargic, that's often trouble because they're not clearing their CO2 because they're in respiratory distress, such as a severe COPD flare. They're not able to get the CO2 out of the bloodstream, and as your CO2 climbs in your blood, you start to get tired, lethargic, and then you can go all the way to basically respiratory failure, and you're approaching being unconscious with the elevated carbon dioxide that's in your blood. Okay? Fingernail clubbing. So if you ever see this is an indication of long-term oxygen deprivation or hypoxemia. So it's at the tips of the fingers, and the nails are curved and the end of your finger is enlarged, and that's called clubbing. So any chronic condition of the heart or lung that leads to chronic hypoxemia can cause clubbing. So cystic fibrosis is a perfect example where they're chronically hypoxic or hypoxemic and they have fingernail clubbing.